The UT College of Pharmacy is pleased to have the opportunity to be a co-sponsor of the McCombs Healthcare Research Symposium. If we're ever going to address all the challenges that we have in U.S. healthcare, it's important that we get together and exchange knowledge, exchange information, network, and form new collaborations to be able to address the challenges that we have. And one of the reasons I particularly like this conference is that not only does it bring together faculty, graduate students, and postdocs across the UT campus, it engages individuals from the private sector and the public sector in Texas as well. So it's really my pleasure to introduce our keynote speaker this afternoon, Dr. Benjamin Crabtree, who's a medical anthropologist and professor and director of research in the Department of Family Medicine at the Robert Wood Johnson Medical School in New Jersey. He has a distinguished career as a primary care health services researcher. He's contributed numerous articles and chapters on both qualitative and quantitative methods, covering topics ranging from time series analyses and long linear models to in-depth interviews, case study research, and qualitative analysis strategies. He's particularly known for his expertise in qualitative research and writes extensively in this area, including the second edition of a book that he edits entitled Doing Qualitative Research. He was also the lead author on a book about developing collaborative research teams, exploring collaboration research in primary care. He's been the principal investigator on numerous NIH grant fundings. He currently has an R01, and he also has a Senior Investigator KO5 award from the NCI. Dr. Crabtree.
Thank you. So, after this morning, so I really enjoyed that first talk this morning, and kind of thinking about public health and primary care, and so we're actually shifting gears here because this is primary medical care I'm going to talk about. But I wanted you to know that I actually do know a lot about primary health care as well. I was started out in the Peace Corps in Ethiopia in the smallpox eradication program. And so I learned a lot about public health there. And then I re-upped again in Peace Corps and did tuberculosis in Korea. So had a background in that as well. But I want to really talk about kind of what's going on in our country right now in the transitions in healthcare. And I was actually given this title, Primary Care, the Keystone for Family and Patient-Centered Care. I added a question mark on the end of it. So in your program, there wasn't a question mark, but I think I'm going to question this a little bit. Now, so what is a keystone? Everybody know what a keystone is? It's that thing up at the top that's holding up, and you have these swear that are so with this metaphor, the keystone is holding up is going to be keeping everything from collapsing. So the real question is this going to collapse down on patients and their families, or is it going to stay up there, this arch? I want to kind of start by asking you some questions. So I want let's think about how well we're doing in our healthcare. And so let's not get carried away. How about this one? How well are we doing on treating sinusitis? How many people think we're doing a reasonably good job? Raise your hand if you think, treating sinusitis. Yeah. How about preventing heart disease? Surely, nah. Huh? Okay, well, preventing lung cancer, we stop people from smoking here pretty well, right? Okay, how about managing people with multiple chronic diseases? Yeah, this is a huge problem coming, so we're not doing so well there either. We got oncology up and running all over. How are we doing for providing care for long-term cancer survivors? More thumbs down. Managing depression? Treating substance abuse? Pretty dismal. So the question is, what's this poor quality from? So here's a hypothesis. Well, maybe it's because, doctors just don't know that they should be doing these things. How about competing demands make it challenging? All right, this one's starting to look like, okay, well, this might be part of an explanation. How about what we have is a bunch of practices out there that were designed with a model developed from 1910 after Flexner, and for acute care and single chronic diseases. So that's feasible. Huh? Yeah. So, and that's why I liked what this morning's talk is. We just don't do this. Actually, I had one of my colleagues and I were talking about this. So the U.S. is said to spend, a lot more on healthcare than any other country, but a lot of other countries actually spend a lot of money on the underlying determinants of health. So if you took their so because they don't have to spend it on the healthcare, so they may actually be spending fairly comparable amount, but it's how they're spending it. So let me tell you a story. I got permission to use this story. This just came out. So this is about Tom. And in late January, just a couple months ago, his father was diagnosed with this pretty nasty leukemia. And this was a shock. So here's his father. He's out jogging all the way through into December, and then now he's healthy, and now he's got this. So because of the diagnosis, he's gone in and has now been hospitalized for a couple of weeks, and is now completing his second round of chemotherapy. So what struck Tom, and what he actually posted this online, was that he sat with his father there, and his father wasn't given any choices about what kind of care was given. In fact, he noted that the nurses and oncologists would be talking in the hallway and other places, and that they would just do the treatment and not even ask the patient what they wanted to do. And a couple of years before, he would have said, "Yep, that's great. They're taking care of me." But now he started thinking differently about it. And he was actually shocked by the fact that there wasn't this consideration. And so what and these are actually quotes from that he put in there. After spending the last 2 years working along with Jack Westfall, who's up in Colorado, who has these patient networks of primary care, it went off like a light bulb in my brain. I just can't shut it off. My observation of my dad's care do not square with the values we are working to achieve in valuing and respecting the patient first and foremost. So this is a fairly typical story, but it's a tertiary care story. So we'll say, how many have seen this diagram? This was done by Kerr White originally in 1961, published in the New England Journal of Medicine, and it was actually repeated in 2001 by Larry Green, also in New England Journal of Medicine. Basically what it's showing is that if you take all adult population at risk, 1,000 people, 750 will have something going on with them, and 250 of them are going to consult a physician. But only one of them is going to actually be in that tertiary care center. And so the majority of them are going to be seen by primary care doctors. And so maybe the story, that Tom's story, is unusual. Maybe primary care is doing a better job. So let me give you another story. So here's a primary care story. So here's Helen. she's in there in her family physician office. Dr. Jones comes in. He has 10 minutes. Very typical, so everybody's, visits are regimented. You have to see a lot of patients. And so he looks at her and says, how many seizures you having, because that's the presenting complaint. But she's been in here, this is 12 times. She has abdominal pain, seizures, hypertension, type 2 diabetes, and depression. This is actually very common to have that kind of constellation of illnesses. And so how can Dr. Jones meet these needs? He's being a system that's going to 10 minutes. That's the choice you have. So can this primary care we have be the keystone that's going to keep this thing from falling down on patients? No. So what we see, because of that, primary care is really in major transitions right now. And anybody who's working in the healthcare knows how rapidly this has happened. Some of it started out, Barbara Starfield, I think many of you would know who she was. So she was a pediatrician at Johns Hopkins, but she studied international systems and published some papers back in the 80s and 90s that was comparing the US with other countries on a whole lot of healthcare indices, and the US didn't come out very well in these. And then the IOM, Institute of Medicine, published their quality chasm, 2001. And so all of these things are starting to push, start a momentum of kind of change, that the system is broken and we have problems. Family Medicine did a report on proposing major designs, and then recently we've had NCQ8, National Center for Quality Assurance, the Affordable Care Act, Meaningful Use. All of this stuff is coming in on practices all at one time. So how many of you know the chronic care model? So this was one of the early, this came out in 1996 or so. Ed Wagner from Puget Group Health up in Seattle. And so basically what he was proposing is the health system, you need to provide certain supports, and if you do that and you have a proactive team that is working with an informed patient, you get better outcomes. So this was 1996. Ed republished it in 2001 or so, about the same time as the IOM report was coming out. And so what we start seeing is this bifurcation point. And this bifurcation point, so if you think back historically, everybody know Flexner? So Flexner that was 1910, the Flexner report, which basically created a scientific basis for medicine. But before then, general practice was still just a mom and pop shop. Oftentimes a physician and his wife were just the physician, and the patients would come in. But even after Flexner, that was the model. So the model was you had a physician doing everything, and they added more staff over time. Health insurance started around 1930. You started getting, so you started need to having billing people and stuff. But the model of seeing care was the same. It was just the physician, and of course, if you start adding what we call non-revenue generating staff, of course, then that puts a little pressure on the revenue generator to generate more revenue to pay for it. And so you end up with this, and this model actually lasted, and then we ended up with this bifurcation point. And this was the accountable care organizations and the patient-centered medical home initiative that has just happened in the last 10 years. But I'm going to go through a little bit of that history. And so this bifurcation, what it happens is you had these small independent practices until around the early 2000s. We still have some of them, but they're going out of business. I mean, they're really, so if you go around the country now, so 10 years ago, like in my state, New Jersey, 80+% of all practices were small private independent practices. It's down to 20% now, and the only ones that are left are the ones that haven't figured out how to sell their practice, or they're going to retire. They've become part of these ACOs and integrated systems. And so we've had this huge shift, this bifurcation. And so to kind of give you a little bit of perspective on this bifurcation, remember you had the chronic care model, IOM report. So in 2000, there was a conference family medicine put together that was, they called it Keystone. Interesting, it's just same kind of Keystone. I guess they were trying to figure out how to hold everything up. And they commissioned a study, and they created in 2004 the Future of Family Medicine report, which said they wanted a new model of care. And then that was different than the way we were providing care, and characteristics of that. And they, as a proof of concept, they created this, what they call and remember this name, TransferMed, because I'm going to bring it back later. So this was in 2006, the AFP, American Academy of Family Physicians, created a national demonstration where they had 36 practices from around the country that were provided technical assistance and stuff to try to become that new model. It hadn't actually been given the name patient-centered medical home yet, because that didn't happen until NCQA really kind of pushed that concept. But this is the TransferMed model. And look at it. It's kind of neat, isn't it? You've got this thing in the middle. You got family and everybody in the middle. And, it's a continuous relationship with a personal physician, coordinating care. And you have practice management pieces, health technology, quality and safety, a care team. So you get into a team model. You have different kinds of continuity, care management. And so this is a fairly robust model with lots of pieces. And then this bifurcation kind of continued after that. So that was 2006, that started. 2007, the joint principles of the patient-centered medical home were issued by the different professional organizations. And then 2007, people know NCQA, is that a fairly familiar, the National Center for Quality Assurance? So they are it's not a regulating, but it's a recognition program. And so the NCQA came up with criteria that a practice should meet in order to become recognized as a patient-centered medical home. Initially, people didn't pay that much attention to it, but the insurance companies picked up on it and other people picked up on it. And so you started getting financial incentives for becoming a PCMH. By 2008, we've started to get all of these initiatives around the country to develop the patient-centered medical home. And so the NCQA, if you look at what they did, so if you say, doesn't that look like just the same thing that was on that TransferMed slide? I mean, it's the same, so it's just the same kind of bucket of kind of here are the criteria. You want good access and communication. You want to be able to track patients. You want to be able to kind of have care management. So you have these things that sounds good, yeah? I mean, it sounds like this would be a pretty good way of taking that old one physician being the bottleneck and creating a team, creating reminder systems and things. So good ideas there. Then 2010, Affordable Care Act comes in, and one of the things that got incentivized in there and pushed was these ACOs, Accountable Care Organizations. And so as ACOs came online, guess what they wanted? They wanted primary care, because it's actually in the legislation, you need to have primary care. And so all of these PCMHs started getting bought up, these new entities, these accountable care organizations, so they started scarfing up all the practices, And of course, then you really put pressure on the practices to become NCQA recognized. And so, and then NCQA upgraded it. So their first ones were maybe a little too low bar. They made it higher bar in 2011, again in 2014. And now here we are in 2015. We are in ACO PCMH mayhem. I mean, it's all over, and it's all over Texas. It's all over every place you go in the country. You know, the whole dynamic is changing. And so we end up with this patient-centered medical home, and this drawing is all over the place, and it has all these whole person orientation, continuity of care, advanced access and stuff. And just recently, we got the new patient-centered medical home recognition criteria from NCQA. So now we have, you know, that this is really being pushed as the future. So what does a PCMH do? So the big piece, you know, it's a team of people in a community doing, you know, good things. But the fundamental tenets of primary care, that comes out of Barbara Starfield's work. And it's really kind of the critical thing. You know, it's about first contact access. So, you know, so if you have a problem, you can go there, get, I mean, they may refer you, but you know, this is a place anybody should be able to go to kind of get into the health system. It should be comprehensive. So it needs, you don't just do one thing. You need to be able to do depression as well as diabetes as well as a sore throat. You know, so you have that range. It's integrated and coordinated, so you're coordinating it with the bigger system. It's about relationships and a sustained partnership with patients and the healthcare system. And so that's the kind of the tenets that is underlying this. New way of organizing the practice. Of course, you can't do that without having different kinds of teams and way people work together. And then in order for that to happen, you have to change the way the internal capabilities of practice, and then you end up with, and what we're finding more and more is you have to change the whole system and the payments structure. So what is the PCMH? You know, so what kinds of models do we see? We actually see different kinds. So one of them we see is called, we would call an addition. You add something to the existing. You can remodel. You can take the current and remodel it. You can do both. You can add something and remodel, or you can basically transform or integrate a lot of pieces. And I'm going to step through some of these ideas right now. So the home as an addition, we see this quite often where you end up with community health workers. You know, so the practice is staying the same, but you end up with community outreach and things to help people kind of negotiate the system, coordinate care and things. So there's actually some real benefits to that. You see it in behavioral health, something that's not very well done in primary care historically. And so adding some behavioral health, usually it was added on, not integrated in. But one really good example, the Vermont Blueprint, beautiful example, a whole state. They created these community health teams to work with the practices. Practices are doing what they did all along, but now they've got people out there kind of finding tracking people with diabetes, tracking people that need behavioral health things. And so you end up with, and they have a registry, and they have practice facilitators to help them get this NCQA recognition. But you can kind of see the practice is staying the same, but they're adding some additional stuff on it. Does that help? Yep, it does help, particularly on the disease stuff. You know, if you focus on diabetes and hypertension and things, and you have a community health workers that are out there to help with those, you can really make a difference. And you're reducing some hospitalizations, ER use, costs go down. So this model, it's got possibilities. How about a renovation? So the renovation is where you take the existing people, you're not adding any new people, but you're taking the existing people and redoing their jobs and helping them kind of work differently together. great example, Virginia Mason, up in Washington State. They adopted Toyota Lean, and I know you know that one. And they basically taught all their leaders and many of the staff Toyota Lean. They actually sent people to Japan to learn, as a system. And what they did was they took their existing people, they created these teams of two physicians, a mid-level. A mid-level is a nurse practitioner or a physician assistant, an RN, 2 MAs, and they all kind of had a shared with a pharmacist. They worked they had a joint workspace where they could work together, and they changed the MA. Do you know what MA? Medical assistant. Sorry about that. So I use these terms all the time. So MA is basically somebody with fairly limited training, usually 6 months, maybe a year and historically, they were used to take blood pressures and put people into rooms and things like that. You have an LPN is a licensed practical nurse, which usually is 2-year, like an associate degree, and then you have RN, which is a registered nurse. And then you have advanced practice nurses, which we call APNs or NPs, nurse practitioners, who are actually function like a clinician. I mean, so just to clear up some of the jargon there. So what they did was they took this traditional MA, which is the low level, upskilled them, and made them flow managers. And so their job was to basically run the place. They told the doctor where to go, what they had to do. They managed all of the paperwork, and by God, everything was done at the end of the day. These really worked well. And what do you get here? You get lots of cost savings. You do really well on the diseases, but you actually end up with a very happy practice. You see, so the practice, people are enjoying working together. Actually, I talked to the people at Bainbridge Island, and they were saying, the physicians who resisted it ended up all leaving. The ones who just didn't like this team model. And then they brought in so they ended up replacing about half the physicians because the physicians were not flexible enough to kind of go with this new model. And then they brought in new people, and the joy in this place is something to behold. So then we have a hybrid, which you do both. This one's pretty, you add some teams in. Good example is Lehigh Valley Medical Associates with my Ruben and my good friend Will Miller helped develop this. And basically, they took the Toyota Lean redesign roles and the Vermont blueprint by creating these community teams. They used the existing people to kind of create these teams. And this model, the practice isn't quite as happy as the Virginia Mason, partially because they're probably getting, maybe it's because Bainbridge Island, I don't have anybody, do you know where maybe they were happy just because they were in Bainbridge Island and not Allentown, Pennsylvania. But there's some really neat benefits for this model. Integration is where you're doing these other things, but you're really integrating all of your different services and professionals together and making them into a really well-functioning group. And have you heard of South Central Foundation? Here's another mind-blowing place. So this used to be an Indian Health Service place up in Alaska. And they basically bought themselves out of the Indian Health Service. They have, it's run by a community board of Native Americans that basically say, here's what we want to do, here's what we want to accomplish. They do the same kind of teamwork of providers, medical assistants, care coordinators, and then when a patient comes in, they add or subtract to the team depending on what the issues are. So that, and a patient's team will change over time depending on the issues. And they've had just remarkable success as far as, I mean, ER utilization's 50% cut. I mean, that's, and, I mean, it's just a really neat place and does a lot of really impressive work. We have to figure out why isn't the rest of the country doing it? That's going to be some of the questions. So here, look at it. Look, everything's good. I mean, they basically provide lots of the comprehensive services. The practices are everybody's. Well, it's very patient-centered. It's patient-run. The disease are targeted and done. So it does well. A lot of FQHCs have a lot of these similar kinds of characteristics because of the community ownership or boards and stuff. So so there's possibilities. So, well, what do you think? These the Keystone? Maybe, but they're pretty rare. So now we have to think, well, what's going on out there? Why are they so rare? Well, which of these models do you take? Well, there's actually other models besides these four. And Ruben knows one that Michael Porter had suggested in a Health Affairs article where, where you really target specific disease, so you have within the primary care setting, you have people that are really focused on diabetes, a team on diabetes, a team on on different kinds of disease focuses. That model has been proposed. So there's these different models that have been out there. But what we see is, here's the reality. This is the reality in my state, by the way, which was it's not a fun reality. But this patient-centered medical home, you're not just building it by itself. That was that old mom and pop kind of thing. This is a different era, and so Ruben helped teach me some of this stuff about complexity science, and so what we see is organizations are going to self-organize according to what we would call a basin of attractions. Now, what are the basins of attractions out there right now that are shaping this patient-centered medical home? NCQA recognition. You saw that. Accountable care organizations and being owned by somebody else. How many of you know about meaningful use? We'll get a little bit more about meaningful use, but that's a huge attractor on shaping what you do. Pay for performance on disease outcomes. And so if you get more money, if you can get your patients under 7 with, on their hemoglobin A1Cs, then that'll shape, so if you get an incentive for particular diseases, you're going to focus on those diseases, I bet. It's like, and then you have employer mandates. And so what happens here, look at these attractors. So here's the NCQA attractor. The biggest number of these things are about using IT. So there's a whole, or using very specific, it was actually diabetes is one of the, so you're looking at those major diseases that are causing the high cost diseases. So NCQA is a powerful attractor, and all practices are hard. They were ignoring it for a long time, but they can't ignore it anymore, because they're becoming because there's the ACO attractor. So now the practices are owned by this bigger organization that really does say, you need, in fact, some of them won't even buy you, and if you don't get bought, you're in trouble, unless you are NCQA recognized, and they actually set up the system to get you NCQA recognition. So there's a lot of different kinds of ACOs. And there's since January 2013, nearly 200 new ones. You have ACOs here in Texas? Yeah. We went, I think we have like 20 now in New Jersey. There were none a few years ago, but it's just really come in. And so we have this drastic shift from private independent practices to practices that are now beholding to a bigger system. And then this one is a huge, as of January 1st, 2015, you started getting a penalty if you're not meaningful. So I mean, there's actually a financial incentive for every practice in the country, particularly if you do Medicare, have any Medicare, to kind of implement these things and look what the kinds of things that they want. I mean, there's nothing wrong with these. But they really do shape how the practice is going to have to think. So they're thinking about, they need to set up systems of drug-drug interactions and drug allergy interactions, big deals. You don't want to have, so you need to set up those systems in your electronic medical record. You need to have problem lists. You need to be able to kind of do e-prescribing to kind of send out things. Active medication lists. These are good things for a practice to have. But when you start putting it together, what does it do? If the organization is going to self-organize to these attractors, you focus on technology. So all three of these, ACO attractor, NCQA attractor, meaningful use attractor, are going to focus on technology. You're focused on disease-controlled care and not necessarily patient-centered care. And you have these corporate mandates. And so you end up with a certain kind of practice in here. And so now the question, so you saw those nice addition renovations and stuff. So now we've got these corporate ones. So are these going to be the Keystone? I don't know. I think they're going to happen, but we don't know exactly how they're going to happen. And so one of the things we need to start thinking about is how do we study these? So that those first four, I mean, people have studied and published about that. So we know something about them. These new ones, I don't think we really know how is it going to impact patients and stuff. So we really need to start doing the research that is getting out there and looking at it, at how they function and what are the impacts of these. And so my team, and you'll see my buddy Ruben there, and Carlos Hines at UC San Antonio, he's the chair of family medicine there, and Will Miller at Allentown. So we've been working together. 20 years. Yeah, 20 years. And over this time, we've done a lot of studies. Holly Lanham has been involved with some of these, and a number of Ruben's graduate students over the years. And so I'm not going to go through all of these, but all of these are NIH R01 funded studies. So they're big deal studies. They were, but what we did was, so those first two on the left, DOPC and prevention and competing demands, were two observational studies just to kind of what is going on there. DOPC was very quantitative, and prevention and competing demands was very qualitative. It was actually, so the first one had 84 practices where we got a lot of quantitative data. The next one, there was only 16 practices, but we spent weeks and weeks in each of them getting lots of detail. And based on these, this is how I actually got in, Ruben and I got together, is trying to make sense of all that data and recognizing that just simple linear thinking wasn't going to make it. We needed to start thinking. We started exploring the complexity science world and complex systems. And so based on that, we came up with an intervention model that was, well, one-size-fits-all isn't the right way of doing it. Let's tailor the intervention. So we got NCI to fund an intervention to do to enhance prevention, using a tailored model with a facilitator going into practice. And we found, yep, it works, but it didn't work every place. So we got another grant to actually do secondary analysis. And then we developed what we actually call it the impact model. But a group of us, Ruben and my other colleagues and I, we spent a year just waddling in lots of data to try to kind of understand. And we developed a model. So this is the model that we developed, and we published this, actually one of Journal of Healthcare Management, back in 2004. And so basically what we were seeing is the top part of this model, those top two boxes, were about what's going on in the practice itself. And what we saw that you had this combination of motivation. Somebody's got to want to do it. But you also had to have the capabilities of doing it. And that was communication, relationships, leadership, even just kind of the resources. So the top part are really kind of what's going on in the practice. But then you have this outside motivators. And the outside motivators, what's happened is the outside motivators have drastically changed since we did this. So, and those are those attractors. Those didn't exist then. And so we didn't pay that much attention to those outside motivators at the time. I mean, there was things like, clinical guidelines and stuff. I mean, those were outside motivators, but it wasn't big. And then you had these choices, but the choices have now gotten really big. And so this thing evolves over time. And so this, based on this model and our thinking, we were given this opportunity. Remember TransferMed from back in that thing, 2006? So the AAFP, the American Academy of Family Physicians, when they put together that demonstration project, they came to us and said, would you evaluate it? And so we said, sure, we'll evaluate it. But you have to give us complete freedom to do whatever we want, wherever the data go, and to do that. And so we spent 3 years tracking and following that. And one of the things, some kind of lessons that we learned from here. So one of them is, practice, yes, indeed, are complex systems. And so, with a lot of interdependent parts. You change one thing, it's going to impact something else. And so you have to actually use system thinking to do it. Change is not easy, is it? It's hard. Relationships matter. Leadership. And one of the things we found is a huge leadership deficit in most practices. They don't teach that in medical school. And a lot of the practices, who was the office manager? The person who was there the longest. Usually it was, sometimes it was the wife, so they were real family practices, or the daughter. But, it wasn't like they had professional, management people, MBAs or anybody, as doing that. So the leadership deficit. Physicians were actually one of the biggest problems. They couldn't get out of they needed to change how they thought about who they were and what their role was. How do they work with? So if you think you're the captain of the ship, it's hard to have a team, unless you're a rowing team. I mean, there's certain teams where that works. But if you want a collaborative, shared team, then everybody has to kind of change the mental models of how they think of it. There's no such thing as plug and play. What we see is everybody says, okay, here's an EMR, just do it, or here's this, just do it. Doesn't work. And it's partly that complexity science. And so this patient-centered medical home still is hard to find. And on top of it all, everything is changing, and our thinking needs to change about how we are conceptualizing it. And there's so now, what do you think? I mean, I don't have the answer to this one. It's really hard to know. But is primary care the keystone? I don't think we're going to know until we do some more work. And so some of that is, here's some hidden questions that we need to really know. Does community ownership change the model? There's a lot of evidence that suggests that it does, and it changes the dynamic in a lot of positive ways from what I've seen. But we need to know more about that. What's the impact of this hierarchical corporate governance? What are the, if you're going to do this corporate model, do you do it at a local, regional, national? What's the best way that can work? What kind of ACO should we have? And what is this patient-centered healthcare neighborhood idea? And then there's this actually, you have a brand new medical school here, right? Not yet. Maybe you have an opportunity you can solve this work for. So one of the things that happens here, current physicians are not really trained to work in this new environment. And we're still training them the same way we trained them before. So we have to change, the current physicians need to transform themselves, the ones that are out there, and we need to train new ones that are different. People, the professionals, and this is not just this is the nurses, the receptionists, everybody, they need to learn the basics of leadership, teamwork, and organizational behavior. I mean, until that's going to be happening. We need new professionals. So if you're creating, one of the things that when we've gone to study these practices, you saw the thing that said MA upscaling. There's no place these places that create these, that do the renovations, they do it with their existing people because nobody's training the people they need. They have to basically train their own. I went to one FQHC, and their whole motto, everybody in the whole place knew it, was recruit for attitude, train for skill. I mean, get somebody with a good attitude in here because we can't hire the skill. We can train the skills, but we need the attitudes. And then you need to get this culture of teamwork and collaboration, both within primary care, but it's also the relationship with specialty care, with the bigger organization. And so here's a model. There was a special issue of Health Services Research. That's a journal that every article was about mixed methods research. This article was done at University of Utah, where they evaluated an initiative they did an incredible job of kind of transforming some of their practices. And so this is the model they used, and you can kind of see that they focused, kind of the process of change, and to contextualize it, they got certain kinds of data. They realized they needed to have what was the experience you have with transformation? So they did, interviewed employees, leaders, patient focus groups to see how is this working. And then they had different ways of measuring outcome and change. This is how we have to start thinking about future research as we're looking at these organizations. So is this, I don't know, we're at this bifurcation. And I think one side of this bifurcation, here's this really neat, we have this opportunity to really construct something that can actually be the keystone for patient and family-centered care. Or thank you.
Time for a few questions. I'm sorry. That's all right. Any questions for Dr. Crabtree? We have plenty of time for questions. Christy?
So one of the issues I see with patients is that once they get to a specialist, like they have a cardiac problem, and they start seeing their cardiologist, their primary care doctor never sees them again. They really don't end up going back because the cardiologist then becomes their doctor and who they see. And so in this primary care medical home or patient-centered medical home, how
Yeah, so theoretically, the primary care practice should be coordinating that, and so that it should be, that because it's not just cardiology, it's going to be endocrinology. Well, but so the typical, patient, so they have, high lipids and they have diabetes. Well, now you've got two subspecialties there, and then if they have high calcium, they're going to need to go to the, some other specialist, and so so all of a sudden you really, and so the ideal would be, one of the things you see in some of these models is this whole care manager, care coordinator position, and that's what that's really there for, is that so it does become patient-centered because it's not doctor-centered, it's team-centered. One of the things was interesting, I was talking with the people from University of Utah recently, and they studied kind of patient satisfaction and other aspects of their model, and they found that patients were just as satisfied with affiliating with a team as they were with their personal physician. So so there's this kind of this thinking, oh no, it's all about this one-on-one relationship. It is possible to have a team relationship, and there's actually good examples of that. If you know oncology, the patients don't bond with the oncologist, they bond with the nurse practitioner who manages everything. I mean, they have lifelong kind of relationships with that. So kind of that care coordinating role is really central for this. And it was in every one of those different models. It's in the corporate model, but I'm not sure they're tracking the right thing. So there are, so one of the things, for expedient reasons, people use what can be churned out of claims data or out of the medical record. And actually, the medical record is actually pretty poor too. I mean, they haven't really been designed. In fact, I hear a lot of physicians complain about them. There used to be, when you had a chart you could read, there would be text in there. Now everything is a boilerplate. You fill in. And so a lot of details lost. But there are, so a lot of organizations now require regular, patient kind of surveys, even Press-Ganey kinds of scores. So there are these ways of getting data about what matters to the patient. And so often, usually, it's really quality of life. How are they able to function? Less than what's their absolute value of a hemoglobin A1C or a blood pressure. But but I think we have to get away from the easy, because it's in the medical record or it's in the claims data. I mean, those are very skewed kind of ways of measuring. Mm-hmm.
And one of the things that I think, my name is Lindsay Mosby, I work for the healthcare practice leader for fraud design in town. And one of the things that we have been seeing a lot in the research and the clients that we're working with is that the actual definition or sort of understanding of what a relationship with a primary care doctor is changing. Mm-hmm. I have a lot of people coming to us, and a lot of patients that I interview saying, I don't have a primary care doctor for my kids. We go to the doctor box because it's easy, it's simple for us to do, it takes me 15 minutes, there's apple juice in the refrigerator, I don't have to wait. So, to your point about, we don't look back means to see what we already know. I think to look forward is to say, what is that going to mean when everybody doesn't have a primary pediatrician anymore and that person doesn't follow your kid through? What is it when that's that person could be somebody different every time?
Yeah.
What is it when you are using Walmart for your primary care? What is it when you are using Uber services like Docs.com, who will come to your house and provide a home visit? Have you guys sort of thought about what is that almost cloud model of care? How do we start integrating that, and how do we start looping that in on an increasing consumer base that is less, sort of, maybe less looking for that deep relationship
Yeah.
thing. Now, clearly, if you have cancer or a serious bronchitis condition, that's a different evaluation.
And I think, so one of the things is you need to study what's available. But one of the good things is that there are people that are really, we think that way. I mean, that there's got to be other models out there. It's, a lot of the world is being constrained. And so, and that's why we start seeing the more innovations in the FQHCs and in the South Central Alaska. I mean, they've gotten away from some of the constraints so that they can actually experiment more with different things. We would need to study how important is continuity, and is it continuity with whom? I think, I mean, my gut feeling is that, if you just go to Walmart and this place with your kids, that you may actually, that may not be good in the long run, without having some type. But we need to study that and really know. But one of the things that we're working with right now on long-term cancer survivors, so long-term cancer survivors, what happens is, they're with an oncologist, and then they're done, and but they've got all kinds of other risk factors from chemotherapy and radiation, and that needs to be paid attention to. So theoretically, oncologists are supposed to be giving a survivor care plan out, but mostly they don't. Mostly they're written in a language that nobody could read anyway, and mostly the primary care people wouldn't know how to read it. And so we're thinking that the best, and I'm working with some people at Sloan Kettering to develop a cloud base so that the oncologist could put things up there that would actually would go down to the patient and back up and into the primary care, so you could actually start finding a way, a cloud-based continuity and in order to really do that kind of comprehensive care. I haven't seen much of that, though. It's actually even, there's actually some interesting caveats to that as well. So the whole concept of the patient-centered medical home is actually from pediatrics back in the 60s. So this you know, it kind of lay dormant for this long time. And it's interestingly, pediatrics of the primary care disciplines is the only one that's thriving. I mean, plenty of people go into pediatrics. Yeah, a lot of much more than family medicine. A lot of the ones who go into internal medicine they only go for 1 year and then they specialize. You know, so those numbers are really skewed. So a lot of people, a lot of the what looks like a general internal medicine residency, because all specialists have to do 1 year, and so they go into that, but most of them graduate. So, but pediatrics is an interesting anomaly in a lot of ways. Yeah, and the models that are out, a lot of what I see now is what they call hotspotting, or kind of focus on that the 2% that cost you, you know, so that, you know, that, I mean, that's a hospital. I mean, that's a kind of a financially based kind of way of thinking. Is okay now if we can, and so then you get care coordinators for, you know, and really just hound those people. But it's the others. I mean, there's a, you know, so how do we keep people from becoming one of them? As that's the goal, you know, so it's not, but right now a lot of the focus is on just that top 2-3% of the really, you know, the ones with congestive heart failure and you know, that are going to be rehospitalized multiple times, and you know, so because that's the insurance companies, that they're at risk for that. But I think from a health perspective is we need to kind of really figure out how to get people from moving up there. And I think you're right. If we just do the episodic, that's not doing it.
I need to respond to that. I think that as long as you're thinking from the physician box and the physician or practice perspective, you're not utilizing community ownership in a broader sense. So if you're trying to apply hotspotting, and you're talking about pediatrics in particular, then you need to be partnering with your school districts and those systems that sit on large databases of information that describe your population. And then be applying that hotspotting or other analysis to it so that you can target your interventions and your prevention efforts in those parts of the community where you see those needs.
Yeah, and that's why the Brownsville talk, I mean, I was really I mean, what we need is to do a combination, you know, so and we were talking at lunch on how to do that.
Anyone has questions?
Oh.
I'm a sociologist by training, although I work in the healthcare system. And I guess maybe I have a comment rather than a question. But you mentioned
So I work for a healthcare system. I work in a building with 300 doctors, and my last 3 visits were to a minute clinic because it was at 8 o'clock at night, and I want to use my vacation day to go to my daughter's graduation, not to the doctor. You know, doctors can be open from 3 p.m. to midnight if they want to.
Yeah, I was just going to follow up on that. From the standpoint of we're talking about primary care, part of the challenge is, are we where people live, work, and play when they're healthy? Yeah. So if we change where we actually locate, the whole primary care thing changes. And more, we've got research coming out that says we don't need the annual physical. And so we are moving towards that. You know, if we're not having the annual physical, what is our touch point other than an episodic care? So if we look at milestones and we put it where people live, work, and play, then I think that we have the opportunity to go and be where they are as opposed to, here we are, come see us.
So, I was talking to, and I get out and talk with a lot of practices and stuff. So the typical family medicine or adult practice, 60 or 70% of their patients are these multiple chronic illness and not the so most of what they're seeing are people that have diabetes, hypertension, obesity, depression, and all these combinations. They're not, so the younger, weller people are going to Walmart or the Doc in the Box and places, but that's not what's being, so there isn't a one solution for this, but the majority of the patients in a primary care practice are multiple morbidity kind of, and it's, if you think about the nature of our demographics, I mean, we're an aging society, we're a, enlarging society. and all that comes with it, so that, I appreciate, that, and, it's the same with the I've talked to the pediatricians, and you're right. That's 90% plus is, doing immunizations, and, and you have to do it because you have schools require you to do certain things, but, kids are generally pretty healthy.
But isn't it because for years we put all our money into acute care and little in preventive care? If we would just switch those percentages from now on, I think our whole population would change.
Yeah, well, that's why you have to do the community things, because, so it's, I mean, that's why I put up there, so, what we're not doing in the United States is paying attention to those, the determinants of health, and so as long as we don't do that, and then some communities do, I just came back from Portland, I mean, there's some unhealthy behaviors there, but there's a lot of healthy people, and, so, they Yeah. And I think one of the things, oftentimes in our, when we're by ourselves, we call it the physician-centered medical home, and not, I mean, which tends to be how they're organized, so it's not really, but I think some of these newer models are starting to kind of get closer to being patient-centered. One of the points I was trying to make there is you can't study and understand the medical practice in isolation anymore. So we used to study practices. It doesn't make, there's just too much of this so you need to understand the community where those are, what are the resources in those. So Elliot Fisher coined the term, healthcare neighborhood. I think he called it medical neighborhood. I like healthcare neighborhood better. But there's all these different resources that patients, and it's not even patients, that communities use. You're not a patient until you step across some line. We have to start thinking differently about the kinds of research. What is the unit of analysis that you're actually thinking of? Because we have to stop thinking of the practice. I mean, we used to think we could just change physician behavior. I mean, everything was CME, continuing medical education 10 years ago. And now we've actually changed. There's still CME, but there's a lot more organizational thinking, so you have these different kinds of facilitators. But now we have to start thinking broader community and system thinking on that. Wow.
I may add to that, then, that we also have the problem of trying to figure out what the interdependencies are between these various elements in the community and between the various changes that are going on. I think one of the things that's happened, and that you and I have seen over the 20 years, has been that it isn't an escalation, but it's an evolution of what is going on, and you've described that very well. And we've got to really figure out how to manage those interdependencies. There is an interdependency between, I think Sister Phyllis believes, between bicycle trails and use of emergency rooms and healthy families. I think that's the case you would make. And how we study and understand those interdependencies. And we're really seeing that in our cancer care study, I think. Really hard for us to even, and we're pretty good at it. It's really hard for us to even think about those interdependencies.
How do we have our financial model evolve along with the delivery model or the healthcare to health model? You talked at the beginning about how in the United States we spend more on health care. In the other, developed countries, if you broaden your definition, they might be spending comparable amounts in other social services. This is the United States. We like capitalism and our paychecks and our fee-for-service. How do we let go of that? Do we have any insight into how we can get the system to evolve to a more, we call it value-based reimbursement? Well, what does that mean, and what steps do we need to take first?
Yeah, and UK has experimented with pay for performance, and it's not necessarily a rosy pasture. So I think the models that I see that, so there are models like group health cooperative. These are, community owned, and they own the insurance. So everybody has a stake in it. So as long as so one of the problems I see with a lot of these ACOs is they theoretically what they're supposed to do is you have a hospital or multiple hospitals, and then you have primary care practices, and the primary care practices, the goal is to keep people from getting into the hospital, so that you want to reduce ER use, you want to reduce hospitalizations and stuff. But hospitals get paid by having people, by cutting people, and by having them in the, and so unless you change that, the ACO, the incentives are not to kind of, so if primary care is really successful with the current model, the places are going to go broke. I'm telling you this in a business school. Yeah, I'm an anthropologist saying this, and yeah, I had to be real careful with that one. But that's fairly easy math.
You know, I think that was really a good comment because I think you can't look at the care model without looking at the business model, and there is no business model for prevention.
Right? Unless you own the whole thing.
Unless you can pay out of pocket.
Yeah.
You got money for a personal trainer and a diet and a nutritionist.
But there's some really interesting stuff starting to happen too. Like if you, so there's been a couple of forays into our data, health data monetization, right? So Walgreens and Patients Like Me partnering up to actually combine all of that chronic care, for the most part, data that is being pulled in by patients like me. We're starting to have to figure out what is my data worth? I know if you want my data, it's because you think it's worth something. So what's the exchange in value there? How are we going to actually start looking at, there's a really interesting company in the Swiss market that's actually looking at paying dividends for patient data. So if you sign up to be part of their research cohort, essentially, and that group gets bigger and bigger and bigger, and they sell that money, they sell your data to that research institute to do research on cancer, whatever it is, there's a data stream, there's a data and revenue stream there, a shared value set. So what are the other models? Like I thought the thing you pointed out earlier about the MAs being trained is right on. That is so right on. The more that we can actually create new valuable job roles too, whether it's home health, whether it's, cloud health, whatever it is, those become ways for us to then tag that data as an adherence thing. Like actually, we see more people are more adherent. Insurance might pay for that. Safer population, sure. I might actually reimburse for that. But it's so new right now, right? We haven't gotten into it.
Rare.
Oh, it's hugely rare. But I think that this is what we're seeing people start to play with these new models, right? We know we can't keep doing what we're doing.
Yeah. You saw those. My examples. They're real, but they're rare.
Sure.
And I agree with your point. We really need a lot more experimentation.
Yeah.
Like I've been talking to people, I think building a health home around grocery stores is all American. Everybody goes to a grocery store.
Yes.
And we're a better place than to talk about nutrition and diet than the grocery store.
Yeah. That's meeting where they are.
Yeah.
Yes, unless you're
Yeah.
To add to that, the grocery store, from an incentive standpoint, I think we have to think much bigger about incentives from an incentive standpoint. The grocery store would be willing to pay to keep you healthy.
Yes.
Because that means you're going to come back every month and
Yes.
spend more money.
Exactly.
And so I think, flipping the healthcare model kind of upside down is one thing, but if you don't expand it to bring in other partners, then we won't get those additional incentives, right? To really
I think we've done.
Crabtree, a round of applause.
Thank you.